Hello, my name is Bruce Roberts, and I'm the Research Strategy and Innovation Officer at FAIR. Welcome to this presentation concerning diagnosis of food allergies. While a variety of blood tests have been developed to determine whether an individual is allergic to a particular food, the oral food challenge remains the gold standard methodology to diagnose food allergies. Now, this entails the oral delivery of a food allergen one at a time in a controlled manner in a physician's office and close observation of that individual to see if they have a reaction. Now, given the oral food challenge is time consuming, so a patient may need to be in a physician's office for up to 4 hours, and it's unpleasant for patients, and the possibility exists that they may experience an adverse reaction. So investigators are trying to devise alternative, convenient, less stressful ways to diagnose IgE and non-IgE-mediated food allergies. To help us understand this topic of diagnosis of food allergies, I have the pleasure to introduce our guest speakers. Dr. Amanda Cox is Assistant Professor of Pediatrics, Icahn School of Medicine at Mount Sinai Jaffe Food Allergy Institute. Satya Shanmugam is Director of Program Management, Manager of FAIR's Diagnostic Challenge Award Program at FAIR. So to begin with, Dr. Cox will elaborate on the classification of adverse food reactions, which can be subdivided into non-immune mediated as compared to immune mediated disorders. Dr. Cox will subsequently describe how these diseases are diagnosed using medical history data, but also in combination with various test results. Satya will then elaborate on the nature of those various types of tests that are employed to aid in the determination of a food diagnosis of particular food allergies. So I wish to thank Amanda and Satya for their respective contributions, and I hope you enjoy these presentations and find them to be informative. Thank you very much for your time.
Hi, my name is Amanda Cox. I'm an Associate Professor of Pediatrics in the Pediatric Allergy Division at Mount Sinai Hospital in New York, and part of the Elliott and Rosalind Jaffe Food Allergy Institute, where I take care of children with food allergies primarily, and I'm involved in research and advocacy for people with food allergies. Okay, so today my talk is going to cover adverse food reactions, and we will go over a broad overview of different types of adverse food reactions in this presentation. I do not have any financial conflicts of interest to disclose. So as an introduction, when an individual presents with symptoms that they attribute to food, the clinician, the allergist, the pediatrician, the primary care doctor must take a careful history to determine if food is the culprit, and if so, what type of adverse reaction the patient is experienced or may have experienced in the past. Foods can cause different types of reactions through different mechanisms and present with different signs and symptoms. The correct diagnosis of an adverse food reaction has very important implications for how you treat the patient and their food reaction and how you manage them. So very broadly, food reactions can be divided into two big categories, non-immunologic and immunologic. And basically this means that the immune system is involved in some types of food reactions and not involved in other types of food reactions. So in this presentation, I'm going to review and briefly discuss many of these different types of adverse food reactions that fall into these two categories. And just as a reference for you, the categories and definitions that I'm reviewing here are described in the US guidelines for the diagnosis and management of food allergy, which was written and sponsored by the NIAID expert panel in 2010. This is a very, kind of a lot of information, but it just is giving you an idea of how we look at adverse food reactions. And many of us kind of think of this group, this IgE-mediated food allergy, which is our typical peanut allergy, anaphylaxis, that type of thing, that's sort of where everything falls. But as you can see, there are many different ways that people can react to foods. And these are the two big categories, non-immune and immune. And again, this is sort of the structure for the whole presentation. I'm going to go through some examples of all of these kinds of immune reactions or non-immune reactions to foods. So a non-immune adverse food reaction has sort of typical features. A food intolerance is one of the ways we describe this. So food intolerance is an inability to metabolize or fully digest a component of food. The symptoms are generally isolated to the gastrointestinal tract. Most of these food intolerances are not life-threatening or dangerous. Again, there are some exceptions, which I will mention. With the food intolerance, the ingestion of the food results primarily in discomfort, and the severity of this discomfort depends upon how much food is consumed. A food intolerance can be due to several sort of factors. It may be related to an individual person's metabolic response, can be due to sort of pharmacologic effects of foods, can be due to toxic or poisonous effects of foods, and there may be other causes of food intolerance that are difficult to classify that we don't know about. There's less information in medical literature about other forms of food intolerance and sensitivities, and most of these are fairly rare and can lead us into some controversial areas, which we won't really cover here. So moving on from the non-immunologic now to the immunologic food reactions, this is where we really use the term food allergy. So food allergy refers to the adverse food reactions that have an immunologic basis. The underlying pathophysiology, which is just a fancy word of saying the cause, determines characteristic symptoms, and it depends on what part of the immune system is actually responsible. In the immune system, we have different arms or different processes that go on and cause different types of symptoms or illnesses or diseases or manifestations. But just very generally, we separate allergic reactions into IgE-mediated, non-IgE-mediated, mixed IgE, and non-IgE-mediated, and cell-mediated. And I'll sort of cover this. I'll try to be very general and not too technical, but most of what you're familiar with or what you think of with sort of the classic peanut allergy is an IgE-mediated food allergy, but there are other types of food reactions. So because the IgE-mediated food allergy is really what I specialize in, what I see most often in my patients, and what I'm prepared to treat and deal with and educate my patients about, I did want to go over a little bit more detail about how a food allergy like this develops and what it is. So to summarize the process of becoming allergic, or what we call allergic sensitization, I'm just going to go through this step by step. So basically, with IgE-mediated food allergy, an individual becomes sensitized to the food first. So they may not react the first time they are exposed to food. And then they produce an allergen-specific immune response involving IgE antibodies. And these antibodies bind to certain white blood cells called mast cells and basophils. These specialized cells, the mast cells and basophils, have the attached IgE antibodies, these that recognize a specific food, and they remain in the bloodstream, in the skin, and the lungs, and other areas of the body. So basically sitting there waiting for an allergen or the food to be exposed to them. This is the same process that happens with allergy to pollen or pets as well. So it's the same process of becoming sensitized to something. So when that person once they're sensitized, meaning they have those cells ready to go, when they're re-exposed to the food, the allergen itself binds and cross-links the IgE on the cells. I'm sorry, I don't have a picture to show you this. It might help, but basically those cells have little IgEs on them. When the allergen meets that IgE molecule, it triggers an allergic reaction. And the allergic reaction happens because these mast cells and basophils are signaled to release the chemicals that result in the allergic reaction symptoms. So the chemicals include histamine and other things. And these symptoms that result are hives, itching, wheezing, sometimes abdominal cramping, vomiting, et cetera. And I'll go through that again too. IgE-mediated reactions, so once you have those cells that are ready to go and they have the exposure to the food that they're specific to, a reaction happens very rapidly, usually within minutes to an hour or two of exposure or ingestion of the food. And anaphylaxis is the most severe form of reaction and can be life-threatening. So this sort of separates it from a food intolerance. I found this nice diagram on allergyhome.org. I thought it was instructive because this sort of diagrams for you nicely all the different parts of the body or the physiology that can be affected by an IgE-mediated food allergic reaction. So skin can include hives, swelling, itching, warmth, redness. Respiratory system would include coughing and wheezing or any trouble breathing, nasal congestion, sneezing, even like symptoms of hay fever. The gastrointestinal system can be affected with nausea, cramping, vomiting, and diarrhea. Cardiovascular system may be affected with low blood pressure, causing dizziness and lightheadedness, weak pulse, and even loss of consciousness. And there are neurologic effects of an acute reaction, including the sense of impending doom or even headache and anxiety. And there can be some other symptoms that are specific, like uterine cramping. And the top foods implicated in IgE-mediated food allergy are this list here, at least in the United States: milk, egg, peanut, tree nut, sesame, soy, wheat, fish, and shellfish. There are many other foods that can cause allergic reactions or that people can become allergic to, but this list includes, it covers the great bulk of patients that we see. So we wanted to specifically with IgE-mediated food allergy talk about what we do to diagnose this type of food allergy. So very importantly, as with really any of these adverse food reactions, you want to take a very careful history and physical exam. So what the patient or the parent tells you about the exposure, the history, the type of symptoms they had, how long it took to react. If this reaction happens with every single exposure, or it's happened more than once, all these things are really important and help with making that diagnosis. We do skin testing in our clinical offices. This means we put commercial extracts or fresh foods onto the skin and use a little device to make a very superficial prick in the skin on the site. And we look for an allergic reaction, basically a local swelling or almost like a little tiny hive, to see if that test is positive. And that's done within the office and gives you results within 15 minutes. There's also a number of different in vitro tests that are available to us for helping to diagnose IgE-mediated food allergy. Something called immunocap, where that's where we look at that allergic antibody level. This measures the concentration, and we can look at allergic antibodies for most foods. Most foods that we eat, we have an antibody test that we can look at. Component testing is a variation of this IgE antibody testing, where we actually look at the IgE levels to very specific proteins in a food, and these may have specific clinical relevance. And we use component testing very widely for peanut allergy, and we do have some for other foods as well. So this is a little bit of a newer part of our armamentarium for very good diagnostics in food allergy. And the other big thing that we do is oral food challenges. And an oral food challenge means that we have a patient come into our clinical office, and under supervision, we have them eat the food and make sure that there isn't a reaction, or if there is, we will, take care of it, of course. And oral food challenges are really, really good when the in vitro testing or the clinical history or the skin prick testing aren't definitive and don't tell you for sure that a person is allergic. We wouldn't usually use oral food challenges if we're quite sure that the allergy is there. But we do have a lot of patients who outgrow certain food allergies that they have as infants or toddlers. And a lot of times, for instance, milk and egg are outgrown. And the food challenge is a really wonderful way to determine that that food allergy is gone. So these are the basic things in our toolkit to diagnose IgE-mediated food allergy in particular. They don't work well for food intolerance and certain other types of adverse food reactions, which we're going to go through. And we do have food reactions that are not IgE mediated, which we wouldn't really call them to be mixed IgE at all. These are non-IgE mediated food reactions. One of the sort of more common ones that we see is called FPIES, or food protein induced enterocolitis syndrome. And in the acute form of this, the symptoms are profuse, repetitive vomiting, sometimes with diarrhea that can lead to dehydration and lethargy, or very low energy. This is sort of separated from the other type of food allergy because the symptom onset is generally 2 to 4 hours after the food is ingested. And if you remember correctly, when I talked about immediate IgE-mediated food reactions, those generally occur within minutes to an hour of ingestion of the food. So with this, the reaction is usually delayed, and the symptoms can go on for several hours, and the treatment is very different. This generally affects infants, or starts off in infants, and the treatment, if the vomiting is extensive and if dehydration is imminent, the treatment really involves medical attention so that the baby or the child can receive intravenous fluid hydration, and some other medications might be given as well to support the patient. But generally, the hydration is what is needed. This is treated by dietary elimination of the food or foods. We find that milk and soy FPIES usually resolves by the time the child's 3 to 5 years of age. For other foods that cause FPIES, it may persist for longer. And with this allergy skin testing, like the skin prick testing and the serum IgE levels that I was discussing before, are not diagnostic. But this is one condition where we do use the oral food challenge in a special setting to determine if the FPIES has resolved in an older child. Another very common sort of food reaction that's not IgE mediated that we see very often in infants is called food protein induced proctitis or allergic proctocolitis. It's often called cow's milk allergy, but it's not related to IgE, so it's a very different entity from the other type of milk allergy. This milk proctocolitis is common in breastfed or standard formula fed infants, affects about 2% of children who are under 4 years of age, does not affect adults, and usually it's seen before 6 months of age. How do we know a baby has this? Well, usually they will present to the pediatrician with blood-streaked stool, mucus, or loose stools, and occasionally diarrhea. Generally, the babies who have this sort of milk protein proctocolitis are very well. They don't have any discomfort. They're growing well. They're gaining weight, and the only sign of it is in the diaper, in the stool. Cow's milk and soy are often implicated, so these are generally avoided. Again, allergy testing, like the skin testing and IgE levels, are not diagnostic and aren't really helpful in this condition. The treatment is just eliminating milk and soy from the mom's diet if breastfeeding, or transitioning the baby to an extensively hydrolyzed or an elemental infant formula. And this generally resolves around 1 year of age, so it has a very good prognosis. So I've sort of gone through almost that entire table of different types of adverse reactions to foods. And to kind of put it together, bring you back to what is going through my mind as an allergist when a patient comes in saying they're allergic to a food or they have some adverse reaction to food. So this sort of goes through what I'd be thinking. Is their history consistent with the food allergy response? This is talking to someone who's not actively reacting. And if I think no, then we discuss the scombroid, the lactose intolerance, the pharmacologic components of foods, and other types of things that could be going on that are more in the intolerance category, or could be related to toxic effect of food or the pharmacologic effect of some ingredients. If I think there seems to be an immune response, I'm thinking, okay, is this IgE mediated or is it not? If it's IgE mediated, like I'm going to point to the common peanut allergy, I want to talk about the triggers. This is where I will do our IgE, the blood testing, skin testing, and think about even doing a food challenge if I'm not sure that testing is confirming the food allergy. If I don't think this is an IgE-mediated food allergy, I may be thinking of more of the immunologic food reactions that are not IgE. And the sort of big categories are this EOE, that was the eosinophilic esophagitis, or eczema, which have mixed immunologic causes. And this involves its own degree of management, or own type of management. And if I don't think that it's EOE or eczema, I may be thinking along the FPIs and proctocolitis, non-IgE-mediated illnesses. So in these cases, the history is going to be very instructive. And with all of our patients, at least with IgE-mediated food allergy, FPIs, proctocolitis, and to some extent, these types of mixed conditions, we want to keep following our patients and reevaluate and see if the disease or the allergy or adverse reaction may have resolved. So this is something that we, pretty commonly are seeing our patients every year for. So this kind of just gives you an idea of what we're thinking when we see a patient who says, I have a food allergy. So I hope this helps you know what's going through our mind, and that we can always work together to go through this thought process. So just in the end, I wanted to provide you with a summary of what we talked about today. Adverse reactions to foods vary with regard to severity and impacts on overall health. We talked about two very broad categories, the non-immunologic and immunologic adverse food reactions. In the non-immunologic food reactions, intolerances are the bulk, and these are mostly non-life-threatening and often just involve the gastrointestinal system. Immunologic food reactions can be much more severe. With our typical, with IgE-mediated food allergy, you can have life-threatening anaphylaxis or allergic reactions. So it's very important to know whether you're dealing with which type of reaction category you're dealing with. A careful medical history is always important, as well as recognizing the typical signs and symptoms of these types of adverse food reactions. And knowledge of this will aid in identifying the etiology. Obviously, making a correct diagnosis is very important for how we manage the condition and how we educate our patients. And the use of the allergy testing that we have available to us, including right now, blood IgE levels, the component testing, allergy skin testing, is only appropriate and useful for some of these conditions, in particular the IgE-mediated food allergies. And so with that, I'd like to thank you for your attention. I hope you enjoyed this discussion.
Hi, my name is Sathya Shanmugam. I'm Director of Program Management at FAIR. And now I'll be talking to you about test methods used along with medical history to diagnose food allergy. So let's take a look at how clinicians diagnose food allergy today. Keep in mind, the correct diagnosis of adverse food reactions has really important implications for immediate treatment, but also for long-term clinical management. Clinicians must take a very careful medical history of the patient to determine if, number one, a food is the culprit, and if so, number two, what type of adverse reaction the patient has experienced. As Dr. Amanda Cox has just shown us, there are various types of adverse reactions to food which are categorized, and we differentiate between IgE-mediated food allergy, which involve the body's immune system, from non-IgE-mediated food allergy, which includes a variety of different symptoms from what we may refer to as classic food allergy. Another set of symptoms may lead us to conclude a food intolerance, which is, again, different from food allergy. As you can see, there's a wide variety of adverse reactions that a person can experience in response to food. So this is why it's so important for a physician to conduct a very thorough and careful medical history with the patient and the caregiver. In addition to medical history, clinicians also use medical tests that, when taken together with a patient's history, can offer a fuller picture of a patient's potential food allergies. And first, we'll take a look at the skin prick test. Now, in a skin prick test, or SPT, the doctor places a small amount of the suspected allergen or food onto the skin, usually on the patient's arm or back. Using a small plastic probe or needle, the skin is then pricked so the allergen goes just under the skin's surface. The allergen is tested next to a positive histamine control, as well as a negative or placebo control using saline. The patient is then observed for allergic reactions like skin swelling and redness, which usually appear within 30 minutes. A large wheal, which the raised bump is called, may indicate the presence of a food allergy. There are certainly advantages to using the skin prick test. For number one, it's relatively inexpensive. The results are very immediate within about 30 minutes. You can also test multiple allergens at once, which is a big advantage, as I'll talk about coming up. And on the flip side, the skin prick test has some shortcomings. First of all, a negative result does not always mean that a patient can consume the food safely and will not react. This test also has the potential for false positives. SPTs can't mimic the digestive process of food, which may affect or alter proteins that your body may react to. You may also need to discontinue medications such as antihistamines or steroids several days before the test. And finally, as you can imagine, this requires adequate skin surface area for testing, which is more challenging in younger children. Next, we can take a look at some of the blood tests used to diagnose IgE-mediated food allergy. We'll start with SIgE, or allergen-specific IgE. Now, immunoglobulin E, food allergies, indicate the immune system is involved, right? There's an immune response to a food protein. SIgE testing measures the levels of different SIgE antibodies in someone's blood. IgE antibodies are produced by the immune system, and when triggered by an antigen, or in our case, the allergen, they travel to cells that release chemicals, causing an allergic reaction. This test has a few advantages. For one, it's relatively simple and quick with a brief blood draw. It can also detect high levels of IgE antibodies. Now, on the flip side, this test does require specialized knowledge for a clinician to successfully interpret the test results. Also, an undetectable IgE level to a specific food is not the same as a negative result. So this is a significant shortcoming when using the test by itself, as this misinterpretation could lead to serious reactions if a clinician tells a patient they can consume a food safely and clinical symptoms occur. Additionally, not all positive IgE values indicate that a patient will experience allergic symptoms to that specific food. Another blood test that is available is called Component Resolved Diagnostics, or CRD. And CRD is used to characterize the molecular components of each allergen. So we're still talking about specific IgE, but now we're getting even more specific. So if we take a peanut as an example, instead of relying on crude peanut extract, CRD looks at specific allergenic proteins within the peanut. This is by using purified forms of an allergen to detect SIgE antibodies against the individual allergenic molecules. There are numerous individual peanut allergens that have been identified, and you may have heard of ARA-H1, ARA-H2, and so on. Research is still ongoing to narrow down the specific components that may be correlated most closely with a diagnosis of food allergy. And this test, which is an ongoing development, may offer more specific and granular information about someone's food allergy, which is a great thing. However, additional data is required to understand the degree to which CRD will give you higher confidence in the results. Next up is a blood test called the basophil activation test, or BAT. The BAT is not yet used at all clinics, but I'll explain that in just a moment. Basophils are one type of white blood cell and are involved in allergic response, also known as basophil activation. There are biomarkers that indicate basophil activation, And these are what are measured in the bath. The IgE antibody that is bound to the allergen also links to the basophil, which causes inflammatory compounds inside it, like histamine, which you might be familiar with, to release, causing allergic symptoms that we recognize. The BAT is currently a flow cytometry-based assay where the expression of activation markers on the surface of the basophils is measured after stimulation with allergen. There are a few benefits to the BAT. Again, it's a simple blood draw. It avoids patient exposure to the allergen. It can also assist to differentiate true allergy from merely sensitization, and it may reduce the need for an oral food challenge. However, this test does require that flow cytometer that I just mentioned, which is both cumbersome and costly to implement into clinics. The assay also requires fresh whole blood samples, typically to be used within 24 hours, and patients may be required to discontinue oral steroids approximately 3 weeks beforehand. The clinical application is still under development, so we may see this coming to clinics in the future. And then finally, let's talk about the oral food challenge. Now, an oral food challenge, or OFC, is a controlled, medically supervised method for exposure to allergen. And as Dr. Roberts mentioned earlier, this method of testing is the gold standard by which physicians diagnose food allergy. In an oral food challenge, the allergist will prepare cups of the suspected food in increasing doses. Then the patient will start by eating the lowest dose of that food, and the allergist will watch the patient for any signs of an allergic reaction, including wheezing, hives, lip swelling, and much more. If the symptoms are not significant, the patient may receive a larger dose until the highest target dose is reached. And in this example here, a patient was able to consume the first 4 doses safely and reacted upon the 5th dose. Now, the oral food challenge is not required in all patients. It's only a small subset of patients that go through the oral food challenge. If you recall, the clinician can go through the totality of a patient's history and test results to identify a food allergy. The OFC may also be reserved for cases where the medical history and other test results do not confirm or exclude the presence of a food allergy. One of the strongest benefits of this test is it's very reliable. The double-blind placebo-controlled version of this is currently considered the gold standard food allergy diagnostic tool. Therefore, it's often used as a benchmark in clinical trials to determine, for example, if an experimental treatment is having the desired effect of tolerating a patient to their allergen. Now, there are several downsides. The patient must consume the allergen knowing that there's a potential for an allergic reaction. This can also lead to an emotional toll on the patient and their family, who may feel stress or anxiety before or during the test. There is a strong limitation of the oral food challenge in that it can only test 1 allergen per oral food challenge instance, and a single test may take from 4 to 6 hours. So that's hours upon hours of patient and family time. Now, everything we've talked about so far is concerning IgE-mediated food allergy. And here we summarize the various pros and cons of each type of medical test used in conjunction with medical history to diagnose classic food allergy. So this is our menu of tests so far. Now, if we take a look at what tests we can use to diagnose non-IgE-mediated food allergy, there is a limited number of options. So we have the oral food challenge, which, for the reasons I just described, may not be the ideal test experience. We also have the endoscopy, which would help physicians take a closer look at the tissues of the gut to understand what the body is experiencing there. And finally, there are other food tests in development. Epicutaneous delivery of allergens, or through the skin, via a skin patch is an investigational method currently being evaluated as an alternative approach. to exposing individuals to particular allergens to diagnose their allergy. On the positive side, epicutaneous allergen delivery may help eliminate the need for an oral food challenge, which again can be very distressing for patients and their families. However, this method is not yet approved by regulatory agencies like the FDA, as it is being trialed, but this may offer a new option for patients in the future. Now, if we have the options of delivering an allergen orally versus through the skin, we can compare across various factors, such as dosing restrictions. As we know, the oral food challenge is managed in a cautious, stepwise dosing fashion to elicit or avoid allergic reaction. But with delivery through the skin, we have a bit more flexibility here. As I mentioned, many patients may not wish to consume a food with the potential for an allergic reaction, and you can bypass this aversion with epicutaneous delivery. Third, frequently we see GI symptoms in the gut, such as diarrhea or abdominal pain, as a result of oral consumption, whether the adverse food reaction is IgE or non-IgE mediated. And these rarely occur when allergen is delivered epicutaneously or through the skin. And finally, we commonly see patients discontinue oral allergen delivery due to adverse reactions. But this is so far uncommon with allergen delivery through the skin. As this method is still under development, we hope to see it as a new option for patients in the future. So to summarize what we've learned about food allergy diagnosis, physicians will first use medical history, then in conjunction with test results, to diagnose food allergies and intolerances. While skin and blood tests exist for IgE-mediated food allergy, but not non-IgE-mediated food allergy, they're considered to be informative, but not definitive. The oral food challenge is still the gold standard for diagnosing food allergy, but only a subset of patients have experienced an OFC, so they may be avoiding consuming certain foods without being certain whether they are truly allergic. As you can see by the limited options, there is an absolute need to develop alternatives to the oral food challenge to diagnose either IgE or non-IgE mediated food allergies. And fortunately, ongoing studies are designed to evaluate alternatives such as epicutaneous delivery to the oral food challenge, which are underway. For more information on clinical research in food allergy, please consult clinicaltrials.gov or reach out to your medical provider. Thank you for your time, and I hope this presentation on diagnosis has been informative, and we hope to see you again soon.